Thanks, Natasha, for having me here. And good morning to all. So I'll be speaking on the 10 pearls in anterior uveitis. So the first pearl of decoding a case of anterior uveitis is know the keratic precipitates. As you know that the keratic precipitates are very important and sometimes can help you to differentiate between granulomatous and non-granulomatous uveitis. The granulomatous keratic precipitates are typically the mutton fat capes. Also, another important entity is that Fuchs uveitis, which is characterized by the stellate capes. But you must remember that these capes and all are, they add in your diagnosis, but they are not the telltale sign of any particular uveitic entity. Coming to this entity like Fuchs uveitis, it is considered as the most underdiagnosed and over-treated case of uveitis. It is often actually missed because we think that it's a heterochromic uveitis, but whereas that in Indian patients, the dark individuals, this kind of heterochromia is very rare. So because of that, you need to look at the pattern of the iris, which will give you the overview that you are dealing with a case of keratic precipitates. Now you see this case, 39-year-old male complaining of blurring of vision post-cataract surgery, diagnosed to have anterior uveitis, treated with topical and oral steroid for 3 months, pigment clumps on the cornea, and the aqueous aspirate showed that it's a methicillin-sensitive Staphylococcus aureus. So sometimes the chronic inflammation, chronic endophthalmitis can actually present with chronic inflammation, and you need to understand that not all keratic precipitates suggest inflammation. Next important sign you need to look is that iris atrophy. The iris atrophy usually indicates the viral anterior uveitis, whereas it can be seen in various other conditions. But few things which will give you idea that you are dealing with a viral uveitis is that unilateral involvement, corneal involvements in the form of some scar, the pigments or coin-shaped distribution of the keratic precipitates, and the raised intraocular pressure. So these are the signs actually will give you an idea that you are dealing with a case of viral anterior uveitis. Now, if you are getting a case of recurrent hyperacute or acute anterior uveitis, you need to suspect the HLA-B27 correlation. These are the HLA-B27 associated uveitis keeps on alternating between the eyes. They will have intense anterior chamber reaction. They present with hypopyon and may have the systemic association like ankylosing spondylitis, psoriatic arthritis, various other conditions. Now also, when we talk about the HLA correlation, you need to sometimes see that the hypopyon can be seen in Behçet disease also. But remember, these are the conditions. HLA testing does not rule in or rule out any particular conditions. You have to look for the other causes, match them into your diagnostic criteria, and then only you can come to a diagnosis. Now, fibrinous anterior uveitis, when we talk about that, you feel that it's always autoimmune or HLA-B27? No. You see this case of 36-year-old female presented with fibrinous anterior uveitis and scleritis. And if you see this picture, this patient was treated in the suspicion of HLA-B27 with oral steroid. But when we tested, the RPR and TPHA was positive. So it is important to understand that sometimes the syphilis can also mimic this kind of conditions. Now this is another male blurring of vision, history of some dust particle while driving. But when we actually took the patient and taken for vitrectomy and vitreous aspirate, because there was a lot of vitreous exudates and all, so this was a case of fungal infection. So sometimes you need to understand that what is going on, what is the particular clinical entity you are dealing with. This is a 13-year-old girl, mother noted white reflex in the eye, and all tests were of negative, and ANA was positive, referred to a rheumatologist and was diagnosed as a case of GIA. So in children it happens because most of the time these children, they present with some of the complications, and complications are the presenting sign of the disease, so you have to be very careful while dealing with that. See here, this is a 2-year-old child with white reflex, again presented when the child developed cataract. Then the parents actually sought the ophthalmologist's opinion, and you can see that there is a nodular swelling over the wrist. So this, when we subjected to the heterozygous, not to gene mutation, it was found to be positive. So these are the variant which can mimic GIA, but these are actually the Blau syndrome we are dealing with. So you have to look for this systemic association while dealing with that. So you need to understand when you are dealing a case of anterior uveitis in children that topical steroid is not the answer. You can't actually treat a pediatric uveitis with only topical steroid. You need to start on immunosuppressive and all. So HLA-B27 uveitis, you see, sometimes it can present with severe redness, irritation, vitritis and all, and it can be actually present like panophthalmitis or endogenous endophthalmitis I like picture, but these are the cases you need to understand. This is basically a anterior uveitic entity. Now, it's not just always anterior. You see, this patient was treated with mainly as an anterior uveitis. Lot of reactions in the anterior chamber, and you can see that it looks like an anterior uveitis. But the posterior segment is having severe vitritis. We did the ACTAP, and ACTAP showed positive for varicella zoster virus. Similarly, another 6-year-old boy, you can see a lot of anterior chamber reaction. But if you look carefully, this was a case of ARN because you can see the confluent retinitis patches or scattered 360-degree in the fundus. So these are the patient you need to identify, look carefully for the fundus picture, fundus signs, because there can be a associated posterior segment involvement of the retina, which can be missed if you don't pay attention to the fundus examination carefully. Now, sometimes you see this is a patient who presented with a anterior uveitis like picture, but if you carefully look here, you can see the some whitish mark in the lens. So this was basically a lens-induced uveitis. So these are the very important thing you have to know. This is another 77-year-old male. You can see here, this is basically a lens-induced uveitis. So you need to understand that lens-induced uveitis. The treatment is not the topical steroid or cycloplegic. You need to go for the lens extraction. Now, this is another patient. You can see they presented with large like exudates in the anterior chamber, and you see here that redness, irritation, everything was there, but it was a case of actually metastatic squamous cell carcinoma. And these are you are seeing that the metastasis which has presented an anterior segment picture. This is again an 8-year-old child. You can see here hypopion, not responding to topical steroid. And when we did the investigation, it's actually showing that high nucleocytoplasmic ratio. So these are the cases you need to be very careful about muscular syndrome. Now, coming to my last point, look for the cause of that uveitis. You have to always remember that there can be something different in the anterior chamber. You see here, this is a history of injury with a insect while driving a bike, and following that he developed anterior uveitis. And you see here, if you can, I don't know whether the picture is clear or not, you can some caterpillar here, and you see here, you can see that hyper-reflective spot. So these are basically caterpillar hair-induced anterior uveitis, and it has to be picked up early. Now, just last I will show one case. You see here, this is a patient, cataract phacoemulsification was done and the lens was placed in bag, and the following that the patient was constantly actually having the anterior uveitis. Now, look carefully what went wrong. This happens when you make sometimes very large or eccentric rhexis, and the single piece IOL, though it is sitting in the bag, you can see here the edge of the square edge of the optic is out, and you can see here there. The schematic diagram is showing there how that square edge, if it is exposed, it can rub the iris and can cause significant inflammation. This is another case. You see same bag in the bag implantation, but large rhexis, the square edge is actually rubbing the iris and causing intense inflammation. Thank you for patience here.
Thank you, Dr. Partho, for that excellent presentation. Since we have time, if anyone wants to ask any questions to Dr. Partho. Yes, please. Help her with the mic, please, someone.
Yes, sir. In one of your case of HLA-B27 associated uveitis, like initially you suspected that, but then you said it, like when you did the vitreous tab, it was MRSA. But when there is no vitritis, then how we can label it as endophthalmitis? Aqueous tab, not vitreous tab, you said.
No, there was some posterior segment inflammation. So, but it was if you see that little bit of vitritis can be seen in HLA-B27 anterior uveitis also.
Yes, sir.
The referral doctor, he thought that he is dealing with HLA-B27
Yes,
and he
sir.
was treating with that. But the
Yes, sir.
patient when came to us, as you know, that already someone was treating with HLA-B27 not responding, and we could see that some atypical picture like chronic inflammation, lumps, some vitritis haze is there. So that's why we did the ACTAP, and it showed that.
Yes,
So
sir.
the idea is that if there is a long-standing chronic inflammation is going on and not responding to any conventional therapy, is the time you should think differently, because infection can come with inflammation also.
Yes, sir. So, and also like in one of the trauma patient, like trivial trauma with dust during bike. So you said it is like it was endophthalmitis. So like how do you differentiate endophthalmitis with panuveitis with no history of trauma, no post-op? How you label that? Like what makes you define the label of endophthalmitis in
Yeah,
such cases?
so this is a very challenging case scenario where you suspect between an endogenous endophthalmitis and a case of panuveitis. So sometimes you need to differentiate between two. Endogenous endophthalmitis patients will typically have some comorbidities, like they can have a long-standing diabetes or not, or sometimes they will have a recent history of some procedure, like it can be tooth extraction or anything also. So, but these are the conditions clinically you can't diagnose that. So if you are not sure that you are dealing with a case of panuveitis, I always suggest don't go for invasive procedure, but at least try to do some basic workup like urine culture, blood culture, and this routine blood examination and all. And side by side, you just investigate the patient for your inflammatory markers and other things also. So then with that you have to take this. But I agree, these are some cases where it is extremely difficult to differentiate between panuveitis and endogenous endophthalmitis. I am not talking about exogenous endophthalmitis, which happens after surgical procedure or trauma.
Yes, sir. And so for caterpillar associated and like uveitis, will just remove the caterpillar and give the usual treatment?
Yeah, that's the actually standard treatment, but you know, sometimes it's very difficult because these will be plenty of the caterpillar,
Yes,
so it
sir.
has become difficult. So we try to treat the inflammation. Sometimes with anti-inflammatory treatment, it can actually resolve.
Yes, sir. Yes. And sir, HLA-B27, like even if it comes positive, if it's a anti-uveitis, one has to give like topical and the systemic therapy. Apart from that, how it makes a difference, like if somebody is HLA-B27 positive, because many times they don't have any like rheumatological problems.
Yeah, so sometimes it can happen that I can be involved even before the systemic associations are prominent. So in these cases, you have to use that. So HLA-B27 uveitis, if it is coming again, we know that we often call it like it behaves like a ping pong. It goes to one eye and then after sometimes it will come here. So the recurrent of uveitis, if it is less than 3 months and the patient is having recurrent attack of uveitis, this is the time even the patient is not having any systemic association, you have to start the patient on oral methotrexate.
Yes.
Or some other
Yes.
drug.
Thank you very much, sir. Absolutely beautiful talk. Thank you,
you.
sir.
Thank you, Dr. Partho. If there are no more doubts, we will go on. You have, okay.
So
Dr. Partho, one more question for you.
So we had a patient with the caterpillar hair in the vitreous cavity. The patient was asymptomatic. We just detected in indirect ophthalmoscopy. Is it necessary to remove it?
Caterpillar here.
Yeah, caterpillar.
Yeah, it's not necessary, madam. If there is any inflammation, then only we should
There
treat
was no inflammation.
Yeah.
And no symptoms also. Accidentally we detected patient came with symptoms in the anterior segment, but there is no inflammation in the vitreous or even in the anterior segment.
Yeah.
But
So,
after 2 months, he came with the one caterpillar hair in the cornea because it is migrating and
yeah, I think it's better to inform the patient and explain him that these are the possible inflammation you can have in future. So if you have significant like floaters you can see, or if you have some blurring of vision, then immediately come because there is a caterpillar here. In a case of a asymptomatic with a proper 6/6 vision, I don't see any indication of doing a vitrectomy in such patients because unnecessary. You will just
okay, thank you.
Sir, I have a question.
stop the music for a minute?
You want me to sing? Or dance? Reduce it. There is a question here. Thank you.
Sir, in cases of HLA-B27 anterior uveitis, you told that it might come, while investigating it might be negative, but it can have systemic, like it can precede, the eye symptoms can precede the systemic. So do we always need to send those cases to dermatologists, even if HLA-B27 is positive or negative?
No, not at all. Because if your rheumatologist is your friend, he is sending you cases, then you can send. Otherwise, why you will send? You can treat it. It's not necessary. So jokes apart, I feel always that sometimes you need to understand that these patients can develop systemic association later. Sometimes you think that it is HLA-B27, your HLA-B27 is negative. Now, one thing you must remember that what method they are doing. There are two methods. One is flow cytometry, one is polymerase chain reaction. So if it is done by the flow cytometry, then again repeat it with polymerase chain reaction. PCR is the most sensitive for HLA-B27. Also, you need to understand that the patients who are HLA-B27 negative can become positive after a variable period of time, like 4 years or 5 years time, they can be positive. So these two things are important.
Okay. So if they are PCR positive HLA-B27, even then we'll manage it by ourselves. We don't need to send.
Yeah, see, starting methotrexate is not a rocket science. You can actually, this is the only immunosuppressive you can start and sleep peacefully at night. These drugs are very good, safe. Imagine we are using for the pediatric uveitis. So just little bit of reading and all, just you need to know what are the things you need to explain the patient and try to take a proper medico-legal consent that the patient knows that what are the side effects and potential risks. That's it.
Thank you, sir.
Thank you.